Chapter 23 covers behavioral and psychiatric emergencies and suicide. So, behavioral and psychiatric emergencies, this patient may present with just unexpected or completely dangerous behavior. This could be from stress, trauma, a mental illness, overdosing on drugs or alcohol, or just a complete underlying psychiatric condition. Knowing if it is a behavioral emergency will kind of outline the treatments of it. So behavioral patients may appear confused and have an altered mental status. A lot of patients with psychiatric issues are very cognitive of the fact that they do have psychiatric conditions. So with those psychiatric conditions, generally anxiety, panic disorders, complete depression, bipolar disorder, schizophrenia, they are generally very knowledgeable of this, and they know and will tell you up front that they do have mental illnesses. Some physical causes of an altered mental status: the medical or traumatic conditions that can alter patients' behavior, such as low blood sugar, hypoxia, a stroke or hypoperfusion to the brain, head trauma, mind-altering drugs or other substances, and environmental extremes such as hypothermia, hyperthermia, a variety of things. Any kind of wide change to the brain or the body can cause an altered mental status. Patients may experience situational stress reactions such as they were just in a major car accident and a family member in that car died, but they're maybe not too hurt, or just some other things that can cause just severe situational issues of stress, anxiety, fear. Big thing with this is don't be rushing a patient. Let them know you're there to help. Get them calm and relaxed. Build good rapport with them. Try to help keep their emotions under control. Just be a good listener to the patient. Don't tell them, "I know exactly how you feel," unless you truly do. Don't lie to them, fill them up with a bunch of fluff. Just be there for them in a supportive manner for that patient. Acute psychosis doesn't mean it's a cute crazy person, just means a sudden onset of some form of psychosis. It's just that patient's inability to basically process and analyze regular information, just causing that mind alteration. So signs and symptoms: may have hallucinations, complete delusions, catatonia, meaning just kind of basically in a coma or just staring, just completely out of it, or just a complete thought disorder, just completely altered. Big thing is just ensure your personal safety and the safety of that patient. So now we'll talk about how to care for behavioral and psychiatric emergencies. The patient's going to present in a wide range of presentations. They can be withdrawn, not want to communicate, or they can be the opposite and completely talkative and just very agitated. They can have bizarre, threatening behavior, want to harm themselves or others. They can just be a wide range of emotions, just a tilt-a-whirl of things, just going back and forth and going in full circles. Basically, identify yourself and your role. Make sure that they know that you were there to help them, that you're EMS, that you're not there as law enforcement trying to take them to jail or try to do bad things to them. Just make sure, build some good rapport with them, speak slowly and clearly, make good eye contact. One reason to make eye contact, they can help build trustworthiness with that patient, and also allows you to be checking to see if they are going to have any behavioral changes. Monitoring eye and forehead changes is the first indicator of behavioral change. This is based on a lot of studies out of law enforcement officer training. So just keep an eye on their eyes and their forehead to make sure that they're not going to grim their forehead, squint their eyes, get angry, and then all of a sudden attack you. Key techniques to assessing them: just mostly listening. Don't be judgmental to them. No matter if you do think they are the scum of the earth, don't let them know that. Just build some good rapport with them, because it can make a much more safer environment for you. Good positive body language. Don't put your hands in your pockets or talk a whole lot with your hands. Keep your hands out front. Be calm and relaxed. Then just always keep an eye on their hands and body motions as well to make sure that they're not clenching fists, puffing their chests, ready to fight. Stay at least 3 feet away from them, out of the arm swinging distance, and use restraints as a last-ditch effort. If you do have to physically interact with a patient for their sake, you gotta develop a plan. Take as many people as you can if you actually have to physically grab a patient to restrain them. Again, this is a very last-ditch effort, so develop a plan, use a code word or a keyword whenever you're going to actually engage with this patient. So plan out that approach, have everybody grabbing limbs, and have an extra person be supporting that head, but keep away from the mouth so you don't get bit or spit on. And with the care, ultimately just be alert for personal and scene safety issues. Treating their life-threatening problems, their A, B's, and C's, and keep an open mind that maybe it's a medical or traumatic cause, maybe it's just not a raging lunatic. Spend some time, talk to that patient, all about building that rapport and trying to get to know them a little bit so that they'll develop trust in you. Encourage that patient to discuss their feelings of what exactly was going on. Let them open up to help calm them down. And don't antagonize this and play along with those hallucinations and egg and want to say, oh yeah, I see the green guys that you're seeing too. Oh, they're coming at you. Don't egg these people on. You're going to make things much, much worse. With suicide, that's the 8th leading cause of death and the 3rd leading cause in younger populations of 15 to 24 years old. There is, however, more studies coming out of increasing numbers of geriatric patients who are committing suicide. Most time, patients who are suicidal only want to harm themselves. They don't want to hurt anybody else. It can be caused from depression, just high stress levels, emotional stuff generally. And as older populations, 15 to 25 and over 40 are at the higher risk. Really young kids generally don't want to commit suicide. Could be some underlying things of extensive drug or alcohol abuse, or that they're not in their current normal mental state. For potential attempted suicide, talk to them about their suicide, if they've had a plan, if they've ever attempted it before, or if they just want to die but they don't know exactly what they're going to do. Patients who generally have a plan, have it written out, are a lot more likely that they were going to definitely attempt suicide, more so than ones who are just openly admitting that they need help or doing it for just attention. Interacting with them personally is very, very important. Don't argue, don't be confrontational, just be open-minded to the situations that they're in. Keeping in mind all safety aspects, and don't forget that you still need to do a thorough assessment on all these patients. Let the receiving facilities know. Good words to use is suicidal ideations, or SI. That's just generally kind of a key word that all the hospitals will know, so that you don't have to blast over the radio that you have a suicidal patient en route to the hospital. Because sometimes they're very embarrassed by it too, so if you can use codes, it helps them too from getting kind of agitated. So, considering stuff about hostile or aggressive patients. Most of the time the dispatchers do pretty good at picking up on clues, since they're the ones talking to the patient or the caller, of stuff going on, asking if there's any guns involved, things like that, and they can be hearing background noises, things like that, and they do pretty good about telling EMS that you need a stage, that police are en route to the scene. But if you do get there, ensure you always have an escape route on every call. If the patient does become hostile, don't threaten the patient, don't try to get confrontation with them. If all else fails, just run away. With the patient assessment, number one thing is the safety, making sure the patient doesn't have anything on them that could harm you. Calm the patient so they don't want to hurt you, and just do good thorough assessments. And if need be, to do those assessments and to get your patient to the hospital, that may mean that you have to restrain, but that is a very, very, very last-ditch effort. If you do have to restrain that patient, however, you need to be sure you have adequate amounts of help. Plan out the action amongst everybody. You make sure everybody's on the same page of what's going to happen. You may have to get a little huddle going on to plan everything out, but make sure everybody's on the same page. Stay beyond that patient's reach until the whole group is prepared, till everybody's ready. And then whenever you do act quickly. One EMT is going to be in charge of talking and calming the patient, trying to almost kind of get them distracted. And then 4 other ones are going to be are responsible for each limb. Restrain all those limbs with approved soft restraints in the supine position always. Always restrain on their back, never on their belly. The EMT is going to be responsible still managing that patient's airway. Ensure that the patient, though, is adequately secured throughout the entire transport so they don't get loose and fight. When they're restrained, get one arm up, one arm down, so they're using ungrouped muscles so they're not nearly as strong. Put a surgical mask or an honor breather on the patient if you're fearful that they may spit on you. Sometimes you get restrained, that mouth's their only defense, so they will spit on you. Continue to reassess and definitely document thoroughly. Now, determining reasonable force is how much force is necessary to keep the patient from injuring themselves or others. And that reasonable determined by how big of a patient is it. Are we going to have to be very strong to get this big old lad to the ground? Their type of behavior, are they extremely violent? Their mental status, will they even know exactly what we're doing? Or do they think we're Martians trying to abduct them? And analyzing the available methods of restraint, whether they have soft restraints, leather restraints, or if the only thing you have is sheeting. Some places don't allow physically restraining patients, and especially without police or medical control orders. Never restrain that patient without proper authorization and enough assistance. Never try to manhandle one person all by yourself, especially if you have not been authorized to at all. An excited delirium can occur whenever there is force and restraint occurring. They'll become just extremely agitated, showing psychotic behavior during a struggle, followed by just they'll quit struggling and can go into complete respiratory arrest and then die. There are numerous cases of criminals, convicts, things like that having to be restrained, and then they experience this excited delirium and die. Patients often hyperthermic and shouting incoherently will just completely flip out until their psychosis basically kills them from the struggle. Generally, it's linked to improper restraining or a position where the patient can't expand their chest. So people putting restraints across their chest, restraining a patient on their stomach. So just always be alert for this and just watch the video that's coming up on excited delirium.
Hi, it's okay. It's okay.
As I'm not.
It's okay.
As I'm not. This is the last heartbeat.
It's okay. It's okay.
But I'm going to
I understand.
Not. Is it gonna die? But I'm going to. Is it gonna die? But I'm going
You're
to.
okay.
Is I'm going to die?
9102 restrict traffic.
Beats.
But
It's okay. What is his name? Tim. All right, let's move. Okay. All right, just relax. Okay, get the medics up. Let's get him on. Strapped down to the cot. You guys got your medicines?
Okay, take deep breaths.
Are we not going to do that?
We need you to breathe.
Hey, what's going on?
It's alright, man. Even gonna rest.
You taking it? No, yeah, Narcan and Haldol. Or, yeah, Haldol.
Tim.
Let's do a heplock.
Yeah.
Let's do it.
You're just gonna do it.
I'm gonna draw it.
I am.
With straps. Plenty of straps.
But I'm gonna grab my balls.
What?
But I gotta grab my balls one last time. It's okay. I can feel I can hear this one. It's weird. Even though I'm not okay, I'm gonna grab my balls. That okay? Though?
Yeah, we got to get you to the hospital.
Isn't that okay? Please, anti-tap my hand. Please, anti-tap my hand. Please, anti-tap my hand. Please, anti-tap my hand.
No, it's okay.
Please,
Don't fight it.
Please, anti-tap my hand. I fought. Please, anti-tap my hand. I fought. Please, and I thought.
We're gonna get you to the hospital.
Please, and I taught.
Relax.
Please, and last time I shook and I taught my. Please, please. And last time I grabbed my balls and
Tim, stop.
last time I grabbed my balls and I shook. Please, and last time I grabbed my balls and I shook. Please, and last time I balls and I shook. Please, and last time I grabbed my balls and I shook. Please, and last time I shook and I grabbed my balls. Please, and last time I shook and I grabbed my balls. Please, and last time I shook and I grabbed my balls and I shook. Please, and last time I shook and I grabbed my balls and I.
Yeah, that's fine.
I'm a tennis bus come on. 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 No, I'm serious. No, I'm serious. This is what I'm about, though. No, I'm serious.
It's okay.
I'm serious. I'm fucking serious. This is what I'm about, though. No, but I love you guys, though.
It's okay.
Oh,
It's all right. It's all right. We're doing good. We're doing good.
Don't kill me. Don't kill me.
Nobody's gonna hurt you.
This is what I'm about. This is what I'm about.
Nobody's gonna hurt you.
Come on.
Nobody's gonna Just relax. Lay your head back and relax, Tim. Tim, lay your head back and relax.
Kaboosh!
We're good.
Kaboosh!
Tim,
Tim, you're all right.
Kaboosh! Kaboosh!
Tim, you're gonna hurt yourself.
I don't want to die, though.
You're not going to.
Seriously,
We're gonna go to the hospital, bro.
Seriously, though.
We're gonna go to the hospital.
No. This is what I'm gonna.
Did that break loose?
This is what I'm gonna die, though. No.
Tim, relax.
Tim, relax. It's okay. Yes, it is.
Not okay.
It's okay.
It's not okay.
It will be okay. You gotta calm down.
Not okay.
You gotta calm down. You gotta calm down. No, you're not.
This is gonna die.
We're going to the hospital.
This is gonna die. This is gonna die.
We're going to the hospital.
No.
Tim. Relax.
No. This is gonna die, though. This is gonna die, though.
Remember, your mom's all worried about you. Try to relax so we can help you.
Mom!
That ain't gonna.
Don't let him kill me! I love you, but this is gonna die, though.
Okay.
This one, all the meat I've eaten, I forgive myself.
Are we good on those arms?
This is gonna be it. I'm gonna.
Satisfied?
Mom! Mom!
Should I do a handcuff also loose in case?
You're questioning liar! You liar!
All right.
Liar! 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 You're the one! Liar! You're the one!
Let's get him out of here.
Broke his back with a shovel! Broke his back with a shovel! Grab a shovel! We have a shovel in the backyard! Grab a shovel and poke his back out! Mom, grab a shovel!
You got it?
Yep. I don't want to kill you. You don't want to kill me? I don't want to kill him. Okay, I don't want to kill him, but we're trying to take care of you. It's me or you.
Not all hospitals are prepared to treat behavioral psychological emergencies. So you may have to choose the correct facility to take that behavioral issue patient to. If you have the patient restrained and they're violent, go to the closest hospital you can. With these behavioral and psychiatric patients, refusals of them and restraining them can cause a significant medical and legal risk. Some laws will typically allow providers to treat and transport patients against their will if they're a danger to themselves or others. So if a patient says that they want to kill themselves, they must be transported to the hospital, whether it's voluntarily or the police take action, or they must be restrained. But if they openly admit they want to harm themselves or others, that is an emergency. So depending on the local protocols may depend on if police have to be present or not. Some psychiatric patients, not a bad idea to have a same-sex provider with that patient. Some of them may, being psychotic, may make accusations of sexual misconduct, especially those who may have to have physical contact or restraint. Can't say, well, when they touched me and restrained me, they were grabbing my breasts at the same time. So be sure You have plenty of witnesses and everything going on with this.
Occasionally, patients will need to be physically restrained during ambulance transport. These patients are usually severely agitated, combative, and violent for a multitude of reasons. Keep in mind that medical emergencies such as hypoglycemia, hypoxia, head injury, and intoxication can cause a patient to become unruly too. Never assume that the patient is simply acting out or trying to be difficult. While you may need to restrain the patient, a thorough assessment and treatment for any medical cause of combative behavior should be happening simultaneously. When the determination has been made that the patient is a danger to himself or others, reasonable force and restraint can be used. Reasonable force is the minimum amount of force used to control the patient. The goal is to restrain the patient, not to hurt them. Physical restraint is always the last option and should never be used as a punishment for a rude or uncooperative patient. Never attempt to restrain a patient alone. Positional asphyxia has been reported in the literature when patients have been hogtied or restrained in a manner that impairs breathing. Patients should be restrained in a face-up or lateral position, never face down. In many areas, law enforcement or medical control must authorize restraint and treatment of patients against their will. Quickly perform scene assessment. Make sure that the scene is safe and that the patient is not carrying a weapon. Have law enforcement ready to assist if the patient is carrying a weapon. Try to have an exit strategy and stay at least an arm's distance from the patient until actually ready to begin the restraint process. When the application of soft restraints is determined to be necessary for the protection of the patient, crew, or bystanders, take the following steps. BSI precautions. Plan your actions ahead of time. At least 4 people are required to restrain a patient. Each person should be pre-assigned a limb to restrain. Rescuers should all act at once to overwhelm the patient. Attempt to grab clothing or large joints. Avoid placing pressure on the neck, chest, or face to avoid interfering with breathing and/or getting bit by the patient. Secure all 4 limbs with approved restraints. The patient should be secured on the ambulance gurney or backboard in a supine or lateral position, usually with one arm up and one arm down. Placing a sheet or blanket over the lower half of the body can help prevent the patient from kicking. It is a good idea to have oxygen on the patient due to the medical causes of combative behavior. The mask will also prevent the patient from spitting on rescuers. Continually monitor distal circulation in restrained extremities to ensure the restraints have not been applied too tightly. If a restraint needs to be loosened, get help and loosen only one limb at a time. Once restrained, do not leave the patient at any time. Consider having extra personnel in the ambulance's patient compartment during transport in case the patient escapes restraint. Do not remove restraints unless sufficient personnel are available to control the patient, usually at the hospital. Do not allow the patient to talk you into removing restraints by promising to behave. ABCs should always be monitored in the restrained patient. Patients that appear to calm down may actually be deteriorating, so be vigilant. Attempt vital signs every 5 minutes in patients whose conditions are changing or are critical, and every 15 minutes in stable patients. Document why and how the patient was restrained. If the patient continues to struggle violently, requiring multiple people for restraint, consider ALS resources for chemical restraint.